Hello, everyone, and welcome to this Medscape live event where we will discuss non-invasive tests for liver fibrosis. I am the moderator of this event. I am Dr. Alina. I am a hepatologist and associate professor of medicine at Mayo Clinic in Rochester, Minnesota. And I'm accompanied by two excellent faculty, my colleagues and friends, Dr. Naim Alkhouri and Dr. Neil Skolnik, whom I will ask to introduce themselves briefly.
Thank you, Dr. Allen. Dr. Naim Alkhouri, transplant hepatologist, and I recently changed jobs, so now I'm the Chief Academic Officer at Summit Clinical Research. Thank you for having me again.
And I'm Dr. Neil Skolnik, Professor of Family and Community Medicine at the Sidney Kimmel Medical College of Thomas Jefferson University. Looking forward to this great CME program.
Great. Thank you for participating, and we are going to go right in. Before we start, we're actually going to remind you that you can ask questions as we go along. We will save some time at the end to answer them. So please be interactive and participate. So we will focus on massold and screening, specifically in primary care setting, and then further going into the specialty or hepatology. And I'll start with the guidance-based parameters in whom we should consider screening for massold. And these are patients who have abnormal transaminases, metabolic risk factors such as type 2 diabetes or prediabetes, obesity in the presence of another comorbidity such as hypertension, high triglycerides, or low HDL cholesterol. Also consider it in those with more than mild alcohol consumption, as they can overlap, family history of cirrhosis, or incidentally found hepatic steatosis on imaging. And why do we discuss about this? We discuss about Massel because it's the most prevalent chronic liver disease. You can see here the prevalence from 1988 era listed on the left all the way through 2021 on the right. And you can see the prevalence of Massel has increased from about 20% to about 38% on recent estimates. And you can see in the prevalence towers compared to other liver diseases such as alcohol-related liver disease or viral hepatitis. There are barriers to early diagnosis, but it is important to recognize them because early diagnosis allows timely intervention to prevent disease progression to cirrhosis and liver cancer. Among the barriers, the first one is the volume. Almost 1 in 3 adults has Massel in the United States. People typically don't have symptoms until end-stage liver disease. Some may present with right upper quadrant discomfort, which may prompt an evaluation with imaging, but not all. And also important to remember that liver enzymes are normal in most individuals with Massel, and in about half of the patients who have MASH, which is metabolic-associated steatohepatitis, the more progressive form of this disease. When we talk about screening, we talk about screening for fibrosis, and that's the main focus of detection. Why? That is because that's the major determinant of mortality in Massel. As you recall, the disease progresses from simple steatosis to early steatohepatitis, and then to fibrotic MASH, stage 1, 2, and 3, and then later progressing to stage 4, which is cirrhosis, which can be associated with a lot of complications. And as you can see here, the mortality starts to increase around stage 2 or higher, and it's exponentially and more and faster once that stage is reached. So it is important to remember that and to also set the stage that the non-invasive test that we will discuss for the remainder of the event focus on detection of fibrosis stage 2 or higher. So with this background, I will hand it over to Dr. Skolnik, who will give us a brief overview of the types of non-invasive tests.
Thanks so much, Alina. And the challenge for us in primary care, Alina's gone over this enormous prevalence, but we don't want to send everyone forward to our hepatology colleagues, nor do we want to get incredibly complicated, expensive tests on everyone. So our charge is to determine out of that large group of people who are at risk, which need further evaluation and how to evaluate them. To do so, there are 3 general categories of non-invasive tests, that's abbreviated NITS, non-invasive tests, that we can use to determine how to move forward. The first are really simple risk scores. The most well-known one is the FIB4, which we'll talk about in more detail in a little bit, that uses parameters that we already have in the medical record, things like platelets, age, liver function tests. Next, which is the next two are next level tests, and we'll talk about where they fit in, are serum-based biomarkers, the most common one of which is the ELF test, Enhanced Liver Fibrosis Test. We'll talk more in a moment. And then elastography, most commonly used in primary care, is ultrasound elastography used in specialty care, the more accurate and precise MRI-based elastography. Naim, I think you're going to go over these in more depth.
Yeah, thank you, Anil, for this great overview. And again, we think about these fibrosis biomarkers as simple scores, and then we have the ELF test that you mentioned. And I want to highlight two cut points with ELF. One is, if you have an ELF over 9.8, this actually indicates that this patient is at risk of progression to cirrhosis, and this is definitely a high-risk patient. And then the 11.3 cut point indicates the risk of developing liver events. And this typically indicates that the patient is cirrhotic, and these liver events include things like the development of ascites, encephalopathy, and unfortunately, sometimes also progression toward the need for liver transplantation. But I'm going to focus on liver stiffness, if we can go to the next slide. And we have different ways, as you mentioned, including ultrasound-based. I think the most validated one is vibration-controlled transient elastography done through the FibroScan machine. This has been around since the chronic hepatitis C days, and it's been tested in every chronic liver disease. And we have validated cut points for patients with massold and MASH. You typically get two numbers with this. One is the controlled attenuation parameter score, CAP, which gives you the amount of steatosis in the liver. We call it the grade of steatosis. And then you also have your transient elastography liver stiffness measurements in kilopascals, and this can help you determine fibrosis stage. A key point that we want to educate about today is that we have several machines that can do this, and they're all ultrasound based, including 3D shear wave elastography. This can be done through a machine called Velicure machine, for example, and you get also your steatosis value and your fibrosis stage. This can also be done with acoustic radiation force impulse, 2D shear wave elastography. So I think, if you don't have access to vibration control transient elastography, make sure you check with your radiology colleagues, because they may have other methods to measure liver stiffness. Of course, here, for the sake of time, we're just discussing the ultrasound-based technologies, but we also have MR-based technologies that might be even more accurate, including MRI PDFF to quantify steatosis, MR elastography to also determine fibrosis stage. And here we are showing you another MR-based test called corrected T1, and this reflects liver fibroinflammation, and it might be a good way to determine the presence of what we call at-risk MASH or high-risk MASH, which is defined as having active disease in terms of liver inflammation, hepatocellular ballooning, and also the presence of stage 2 fibrosis or higher. So with this brief overview of all the tests, I'm going to hand it back to you, Neil, to tell us how to implement these tests in the screening guidelines.
Sure, such an important overview, Naim. So we see a patient. The decision initially is to screen individuals at high risk. Who are those? People who have obesity, who have diabetes, who have multiple metabolic risk factors. And the primary form of screening is going to be the FIB4 score. FIB4 score is either already in your electronic record. You can pull it up on your phone. You can pull it up on a website. It's in MDCal. You put in the parameters, and then it spits out to you a score. There are 3 cutoffs. If someone has less than 1.3 on their FIB4 score, they go into the not anything else needs to be done regarding MASLD at this point in time. Periodically rescreen with the FIB4 and make sure we do what we can with metabolic risk factors ranging from hypertension to triglycerides to cholesterol to obesity. If someone has a FIB4 score greater than 2.67, the likelihood that they have stage 2 fibrosis or greater is so high that we don't need to do transient elastography. The recommendations are they go to see the hepatologist and have the appropriate workup to look for high-grade fibrosis. About 2/3 of people fit, though, into the intermediate category, between 1.3 and 2.67. In those individuals, there's too many people to send all of them on to our hepatology colleagues. There we do a second level risk assessment test. And that can be either the ultrasound that Naim went over, transient elastography, or it can be a blood test, ELF. If someone has a VCTE score less than 8, they go back into the continue to screen periodically category. They have a low likelihood of F2 or greater fibrosis. If their ELF score is less than 7.7, again, similar to what we just said about VCTE. Intermediate scores or high scores, and the high score on the ELF is greater than 9.8, but even an intermediate score or a high score needs to go on to have the more accurate assessments like MRI, elastography that are done by our hepatology colleagues. So fundamentally, what we are doing is seeing a large group of people, and we are continuing to narrow in on which people are at highest risk of having F2 or greater fibrosis, and then sending those people on to our hepatology colleagues. When they get there, Naim, you were going to go over what's done there.
Thank you, Neil. So I think you highlighted very nicely that in primary care, we want you guys to focus on sequential testing. And you start with the cheapest and simplest test, which is FIB4. Secondary care or tertiary care and GI hepatology clinics, what we do is typically simultaneous testing. We have the FIB4, we have the transient elastography available on every patient we see. And if all the tests are concordant and they show low risk or high risk patients, then usually you got your answer and you can make some treatment decisions. If you have discordant results, then you may need to resort to another test such as MR elastography, potentially CT1. And if you cannot actually figure out the severity of the disease based on the non-invasive test, it's okay to still do a liver biopsy in selected cases. And by doing this combination or simultaneous NIT strategy, and then maybe resorting to a more sophisticated NIT in discordant cases, I can tell you that in my practice, we avoid doing the biopsy in the vast majority of patients. Only about 5% of patients we see with Massel end up needing potentially a liver biopsy down the line to determine the disease severity. Now, moving on to how to select patients through pharmacologic treatment. In the next slide, I'll show you the recommendations by the expert panel. And this is basically to select patients for resmetirom, which is the only FDA-approved treatment today for MASH with F2, F3 fibrosis, but potentially also for future therapeutic agents, and some of them might be approved later on this year. So the way we do this, we divide patients into 3 zones. We have the green zone. This is where it's very clear that this patient needs to be treated with pharmacologic treatment if they don't succeed with the lifestyle intervention. And if you focus on transient elastography, that green zone is with liver stiffness between 10 to 15 kilopascal. You can push it down to 8 kilopascal also, but maybe you need another test to confirm that you're dealing with significant fibrosis. So this is the green zone based on transient elastography. We then move on to the red zone, where we don't want you to treat with pharmacologic treatment because these patients may have cirrhosis. And the cut point we suggest here for transient elastography is more than 20 kilopascal. And then you have the yellow zone. This could be kind of like in-between zone, where your liver stiffness is between 15 to 20. And the issue here is that, some of these patients may have cirrhosis, but about 2/3 of them actually don't have cirrhosis. If you biopsy them, they'll end up with F3 fibrosis for the most part. And to determine this, you want to look at the entire picture, make sure this patient has a completely normal platelet count, that you obtain full abdomen imaging, make sure they don't have splenomegaly, make sure the liver contour is smooth, and you rule out the presence of cirrhosis, and then you can consider some of these patients for treatment. Again, the idea here is, categorizing patients into green zone, yellow zone, and red zone. And you don't have to do this based only on transient elastography. You can do the same based on MR elastography. And you see the cut points listed on the slide. So the green zone is between 3.3 to 4.2. The red zone is MRE more than 5 kilopascal. And we have some combination tests that we utilize also in specialty care, like the FAST score, MASS score, and MEFIB. But again, this is how we select patients for treatment with resmetirom today. And I suspect that we will use the same strategies for future therapeutic options. So with this, I'm going to hand it back to Dr. Allen to take us home.
Great. So thank you for the great insights. Please add your questions, anything that hasn't been clarified so far. We still have about 10 minutes in this event. But I would like to summarize the key points. The main one is to remember to screen for steatotic liver disease in those with at least a component of metabolic syndrome, and especially in those with type 2 diabetes. I think we mentioned it, but I want to make sure it is really honed in point that those people should be screened, because about 2/3 of them have hepatic steatosis in excess, and about 1 in 5 already have fibrosis that is clinically significant. So please remember those with type 2 diabetes. I'll summarize the risk stratification, which starts with FIB4 and is followed by elastography or ELF, which is the blood-based test, but other NITs may be part of future guidelines. Remember to refer to hepatology or GI if fibrosis stage 2 or higher is estimated in any of these NITs. Remember, there are MASH-specific therapies, the THR beta agonist that Dr. Alkhouri mentioned, resmetirom, and then there are GLP-1 receptor agonists such as semaglutide in the process of FDA approval. So it is important to identify them so we can treat them. And remember these cutoffs for the NITs that we use currently to select candidates for therapeutic agents, those in that window of not too early or not too advanced disease, the VCTE cutoffs of 10 to 20 kilopascals, MRE cutoffs of 3.3 to 5 kilopascals, and F score of 9.2 to 11.3. So I hope this was helpful. I think I'll keep this conclusion slide and we'll go into some questions. I think before we move to the audience questions, I want to add a clarification. Maybe one of you can comment on the FIB4 and age dependence and the change in cutoff based on age, because that's important and it's sometimes hidden in the guidelines and not readily available. So whoever wants to comment.
Good point. Naim, I'll let you take that one.
Thank you, Alina, for pointing this out. So as we know that FIB4 has age, AST, ALT, and platelets, and since age is part of it, in older patients over 65, you have to adjust that low cut point, the 1.3, to actually 2.0, because otherwise you will be doing, another test in the vast majority of patients. So again, if you have a patient who's 75-year-old, you calculate FIB4, it comes back at 1.4 or 1.5, that's okay. You don't need to send them actually for transient elastography or ELF. You can reassure them. But if the FIB4 is more than 2.0, then you need to follow the algorithm. Another caveat of FIB4 is also it doesn't work as well in young adults, younger than 35. So you need to also be careful. So I think the sweet spot with FIB4, based on the algorithm that Neil shared, is between age of 35 to 65. Over 65, you need to modify. Younger than 35, I would suggest that you rely on a different test than FIB4.
Great. And then while we're on the age topic, there's a question here coming from one of the members in the audience talking about indications of NITs in pediatrics.
Yeah, I have experience in this. I think, it's been a little bit of a disappointing story so far with, establishing the cut points and generating data in the pediatric population. Of course, we're more reluctant to do biopsies in this population, so we can't compare the NITs to biopsies. But there are encouraging data now utilizing MRI PDFF and MR elastography in the pediatric population. So I tend to rely on these more than FIB4. As I said, it doesn't work in this population. Transient elastography, you have to take it with a grain of salt with the cut points also. They're not as validated as the adult population. But having said that, I still, if I have a 17-year-old, I still look at the AST to ALT ratio, and then I do transient elastography with FibroScan first. But then if I see high values, then typically I like to confirm with MR elastography plus PDFF. If my FibroScan is really low, that can provide some reassurance that we have time to work with the lifestyle intervention. So to summarize, I guess negative predictive value is still okay, but positive predictive value in the pediatric population needs, more studies. And I would recommend that, if you see high values based on FibroScan, that you still do MR elastography, or you can do a biopsy, and if needed.
Great points. Thank you, Naim. Dr. Skolnik, we have a question. Is Masel reversible? Comment on that.
Well, yes, both the therapy. So first, massold is different than MASH. So a lot of steatosis in the liver without ballooning, without inflammation, is essentially adipose infiltration of the liver. And forever, the primary intervention that's made a difference has been weight loss. Now, the problem is, until recently, weight loss was extremely hard to achieve and sustain. We now have highly effective weight loss medicines. The two that are on the market are semaglutide and tirzepatide, with levels of efficacy being in that order. In people without diabetes, about 15% weight loss and 22% weight loss, respectively. Both of those medicines now also have data, semaglutide phase 3 data, May New England Journals, tirzepatide phase 2 data reported a year ago in this past June, a phase 2 trial of tirzepatide for actually not just MAFLD, but for MASH. And in both of those clinical trials showing not just slowing of progression of fibrosis, but reversing fibrosis in a percent of people, not in everyone. So there's enormous promise here, and one of the compelling reasons to treat obesity with medications is to stem the progression of MASLD, and in fact be able to, in some of those people, reverse MASLD. So in essence, when I see people in the obesity clinic, one of the things I look for is MASLD, and that becomes part of my argument with insurance companies as a reason to support treatment for those patients.
And an important thing to add here, which is sometimes a surprise to patients, is that fibrosis is reversible as well.
Yes.
That's very important, which is why, again, gets to the point of non-invasive identification, so that we know the baseline and who we need to act on. And those with advanced fibrosis, we need to be more aggressive and act fast for them to reverse, but it is possible. Great, thank you. I think we have maybe a quick question with what is the most used algorithm for diagnosis of MASLD? Maybe Naim, you can comment. I don't think there's one more than the other, right?
Well, I mean, I think, to make the diagnosis, you just need to show evidence of steatosis in the liver, and that can be done on, basic imaging, ultrasound, CT scan, MRI, and you need to show the presence of at least one cardiometabolic risk factor, and rule out excessive alcohol consumption or other chronic liver diseases. Once you make the diagnosis of MASLD, I would say the most common risk stratification algorithm is the one that Neil shared with you, starting with ELF, and then going to a secondary test when the ELF is more than 1.3, and that includes VCTE and ELF in the guidelines.
You mean FIB4 1.3?
Oh, yeah. Did I? Yes, yes.
Great. Perfect. Just a quick, there's a quick question there with cut points used when assessing or confirming progression to cirrhosis. Those are the higher cutoffs listed here on the screen. And then maybe another important question we didn't really talk too much about, but why non-invasive tests matter for prognosis, one member wonders.
Yeah, I mean, I think we have a lot of data now showing the prognostic value of these tests, including FIB4, transient elastography, and ELF. In fact, ELF was, approved based on its prognostic ability to predict progression to cirrhosis with the 9.8 cut point, and then its ability to predict outcomes based on the 11.3 cut point. More recently, also, we have a couple of large studies that showed that changes in transient elastography over time can predict outcomes. And it seems that patients that decrease their transient elastography by more than 25 or 30%, or decrease it by an absolute value of 5 kilopascal, they have better outcomes. And the opposite is true for patients that increase the transient elastography by 25 or 30%. And this goes back to the fact that biopsy is the imperfect gold standard, that we need also tests that go beyond the biopsy, and we don't want to always compare our NITs to biopsy. And now we have these studies showing their prognostic value. So having transient elastography by itself is not good news.
Great. I think one additional maybe point for us to discuss on this specific NIT and Massel piece would be caveats of when to use one versus the other, what consideration you would have or limitations for either of these biomarkers. Just a brief minute answer.
I mean, go ahead. No, please.
Well, I think if we're thinking about transient elastography versus ELF, there's a little more confidence now in transient elastography. I think that's the one people are used to getting. And that's really the only thing that, in my mind, argues for that out of the chute. ELF, it really is a lot easier test to use. Someone's getting their lipids, they can get it's just a blood test. So it wouldn't surprise me if we slowly move in that direction. Right now, the default is transient elastography. But Naim, I'm really interested in your thoughts here.
Yeah, I mean, both tests have limitations. Transient elastography, definitely in patients with very high BMI, above 40, could be limited, especially the ultrasound-based technologies, not MRE. Also, if your ALT or AST are higher than 200 units per liter, you should not be doing a transient elastography. So this is important, for the audience to know. And then, of course, if you have ascites, obviously this patient has progressed, and you don't need to do transient elastography. You're not going to get accurate results. ELF is a fibrosis biomarker, and of course, it's mainly from the liver. But if you have another fibrotic disease, that can drive the ELF values up. It's also affected by age. So every test has limitations, and that's why we always preach the importance of looking at the entire clinical picture and also not interpreting the NITs in a vacuum. High transient elastography in a Hispanic patient with type 2 diabetes and family history of MASH cirrhosis might mean different things than high transient elastography in a 25-year-old with a BMI of 45.
Right. Great. I think this was fantastic. Thank you so much for covering such a wide range in such a short time. Thank you to the audience for the nice questions sent, and I hope they all learned. And with this, we end this activity. And thank you very much again, Dr. Alkhouri and Dr. Skolnik.
Thank you, Dr. Appreciate you.
Bye now.